Guten Abend. I said that well, yeah. Good afternoon, everyone. Welcome to the Satellite Symposium here at ISAM. This is brought to you, it is organised and fully funded by Camurus. Camurus is the manufacturer of Buprenorphine, also registered as Brixadi in the US. And in this session, we're going to be going through a number of issues around the use of long-acting injectable buprenorphine, but taking it very much from the perspective of a patient-first approach and how we individualise and tailor treatment to the needs of individual patients. I'll introduce my colleague in a moment, but just first some housekeeping. If you can please turn your mobile phones to silent, just so it's not interrupted. But if you can also have your mobile phones ready, because during the course of the session, there will be a QR code to scan, and from there, there'll be some questions. You'll be able to provide feedback during the course of the talk. Hopefully, most of you have seen that there's some lunch bags, so you won't miss out on lunch. So people want, if they haven't got them yet, they're still available at the front. And also at the end of the session, we would greatly appreciate if you can also provide some feedback on the session, and you can access that by scanning the QR code on the information flyer, and we'll also have it available again at the end. Okay. Some disclosures. My name's Nick Lintzeris. I come from Sydney, Australia. I've received research funding from Camurus AB for research using long-acting injectable buprenorphine, and also honoraria from Camurus and Individualized for providing professional education. And also my colleague here, Dr. Mark Vogel, has participated in advisory boards for a number of companies, including Camurus, Hexal and Individualized, and also has provided professional education for those companies. Just to highlight that the information we're going to be providing today is part of an exchange of ideas. We may and probably will be talking about the use of these medications that may at times be off-label, but it's in the context of professional development rather than us making statements beyond the product label. So, once I finish my welcomes, then I'll introduce Mark Vogel. He's going to walk through some of the high-level issues around how we tailor treatment to individuals, specifically looking at some of the medication options we have available, and then I'll focus on then how we apply that with the use of long-acting injectable buprenorphine, especially around issues around how we move between medications. Hopefully these are the learning objectives. Hopefully you'll walk away with a better understanding of the treatment landscape for opioid dependence and treatment goals, recognise the importance of informed consent and patient preferences in choosing treatments, to describe the techniques available for transferring between medications, and hopefully provide an opportunity to share your own insights and experiences as part of a panel discussion towards the end. So with no further ado, I'd like to introduce my colleague, Dr. Mark Vogel, who comes from Basel in Switzerland. We're really fortunate to have Mark here because you'll see in a moment, when we're talking around medication options available to us, Mark comes from Switzerland, and Switzerland is probably the country with the broadest range of medication options available. I come from Australia. We have a very limited range of medications we can use, but Mark from Switzerland will be able to talk about some of the options that he has available in his country. So over to you, Mark. Thank you.
Thank you very much, Nick, for the introduction, and thank you very much for you all for attending and probably postponing your lunch. That's very nice of you. I'm the head of the addiction department in Basel. And like Nick said, we're very fortunate. We have really a range of medications to choose from. And I wrote this a little bit from the perspective of a Swiss provider. So I hope you will still be able to benefit from that. So opioid agonist treatment, I'm sure you're all aware of that. That is the treatment of first choice for opioid use disorders. It effectively treats the symptoms and sequelae of opioid use disorders, such as withdrawal, overdose, craving, but also increased stress reactivity. On the treatment goals, they do not necessarily include abstinence, but it's usually a reduction of use and also retention in treatment, because we know that only patients who are retained in treatment will be able to benefit from treatment. It's open-ended, sometimes lifelong, and it typically involves some psychosocial support, or at least the offer of psychosocial support, and it's up to the patient whether to use it or not. We know that it substantially reduces mortality, and we also know that it's probably the most effective treatment in psychiatry and one of the most effective treatments in medicine in general, with a number needed to treat of 2. So I brought you a clinical case, pretty archetypical case. It's Mr. M. He's aged 29 years. He presents with daily and ongoing injectable use of heroin for the previous 3 years. His concomitant intermittent use of crack cocaine by inhalation and also benzos. He lost his job as a painter recently, and his daily life really only revolves around buying and selling drugs at the moment. He has repeatedly developed abscesses, and he's HCV positive, so very typical history. And of course, he has fulfills diagnostic criteria for opioid use disorder. Pretty clear, okay, we should offer this guy opioid agonist treatment, and he has not sought treatment before. So now it's up to you. Please take out your smartphones and scan the QR code. Which of the following treatments would you recommend in the first instance for this patient? Of course, there's multiple choices possible if you think multiple choices are suitable. And let's say what you guys say. Right. All right. So we got what we got here is pretty colorful picture I'm seeing already. Most people sublingual buprenorphine, some long-acting injectable buprenorphine, but buprenorphine seems to be the favorite here. And then methadone, levomethadone is next, slow-release morphine, and diacetylmorphine is the last. So I'll leave this in for a sec. Yeah, I think we get the picture here. But now, not a clear picture, right? So that it's not the one and only substance that should be recommended as a first-line substance. So what kind of substances do we have? What kind of, for treatment of opioid agonist treatment? There's actually 2 or 3 major kinds. One is the full agonists, such as heroin, methadone, or morphine, that can produce a maximum effect when they bind to the receptors. But we also have a partial agonist drug, which is really only buprenorphine, which we use, which does not produce this maximum effect, but only a submaximal effect, which has the advantage that, for example, it's very hard to overdose on buprenorphine itself, if not impossible, because there's a ceiling effect to the effect. There's a submaximum effect, and you cannot surpass the threshold of respiratory depression. I'll show you this slide in a sec. And there's also antagonist drugs which fully block the receptors, such as naloxone or naltrexone, which are also available for opioid use disorder treatment, but not recommended as first-line treatment usually. This is a slide illustrating the respiratory depression and the ceiling effect that you have with a partial agonist such as buprenorphine. All right. So what do the guidelines say about our case here? What do they recommend? And you see there's 2 guidelines. I don't want to walk you through every detail here, but Canada and the European Union, they have a clear recommendation on buprenorphine naloxone or buprenorphine or methadone. All the other guidelines do not have a first choice recommendation. There's all kinds of other substances recommended. Diacetylmorphine, extended oral morphine, naltrexone, so all kinds of substances in there, but no clear front runner. And this is this picture you get when you look at oat medication in Europe, and I took this data from the European Union Drugs Agency and threw in Switzerland as well. And what you see here is that there's countries such as Estonia on the left-hand side. I can show you that here. I should be able, yeah. Which practically exclusively use methadone, which is the dirt-colored bar here. And then there's countries such as Turkey or probably Finland, which use mostly buprenorphine. And then there's some countries which are really doing their own thing, such as Austria, very special. And then there's countries such as Switzerland or Germany who have a pretty much a mixture. So there's no really, what we can say is that this pattern obviously is not a pattern determined by a clear evidence and a clear front runner, but it really reflects the situation that different medications are available in different countries, different settings, different traditions are around. So what do you grow up with? What do you learn? And also, of course, maybe some evidence. So the question for us would be, what could the choice of medication for a patient be based on, right? If we look at this picture, so what should we really use for decision? We already talked a bit about the mechanism of action. We could base it on that. But the next thing we could look at is efficacy in terms of treatment retention and reduction of substance use. So let's look at the efficacy. And those of you who are familiar with Alice in Wonderland, I'm showing you this slide because it's the dodo, and the dodo wants to do a race, right, in Alice in Wonderland. And it's a race when everybody can start running whenever they want, stop running whenever they want, and everybody has won, and everybody must have prizes. It's a bit like that with efficacy of the different medications for opioid use disorders, and it's usually something that we invoke also for different schools of psychotherapy. So we know that there are several systematic reviews and meta-analysis which in summary show that there's no conclusive evidence of superiority of methadone, buprenorphine, or slow-release morphine over one another. They're all similarly effective, all are superior to placebo. And we have to say that the evidence base is much better for methadone and oral buprenorphine because simply they've been around for much longer than slow-release morphine or long-acting injectable buprenorphine. Maybe one thing important to note is that most studies show that injectable opioid agonist treatment, such as with diacetylmorphine or hydromorphine in Canada, is superior over methadone in treatment-refractory patients, so for reducing illicit street heroin. So this is really something, maybe this therapy is more effective, but it's also a clear second-line therapy. It's really recommended only for people who have not responded sufficiently to the other opioid agonists. Okay, so we know, they're all pretty much equally effective, so hard to base it on that. We could base it also on individual patient and treatment-related factors. So I'm not going to go into detail in every one of this, but individual patient factors to take into account obviously are comorbid conditions such as renal or hepatic conditions or respiratory problems, COPD, cardiac problems. Maybe tapering, if patients want to come off the opioid agonist treatment, it might be easier, for example, with buprenorphine or buprenorphine depot. Travel are things to consider, cost, black market value, stigma, pressure to divert, psychiatric comorbidities, pain management, all these things could be factored in. And there's also treatment-specific factors. If you have a patient, for example, that is a rapid metabolizer for methadone, it's pretty obvious that you have to have very, very high doses, and it might be a better idea to switch to another medication such as buprenorphine or slow-release morphine. Drug-drug interactions, galenic formulations depending on where you work, what is most convenient for the patient, and frequency of dosing equally. So a depot you can dose once a month. The oral buprenorphine you can dose every 3 days if you want to. Methadone is usually dosed once a day. Some or many patients in our settings really like to dose it twice a day. So we have that. We also could base it on adverse effects, right? Many patients suffer from adverse effects, and unfortunately the evidence base is not really, really good here. And a lot of the evidence we have does not come from opioid use disorder populations, but rather from pain treatment. So it's not clear whether we can really use all that evidence or not. What's really clear, and we did a meta-analysis on that recently, is that there's less sedation and overdose with buprenorphine compared with methadone. We're also sure that there's less QTC prolongation with the other substances compared to methadone. You see that here. One of the complications of QTC prolongation up in the corner is the ECG with showing a torsade de pointe, tachycardia, which can also lead to cardiac arrest. We had a symposium on that yesterday, very interesting. Other important adverse effects to consider are constipation, sweating, nausea, insomnia, libido, sexual functions, weight falls, or neurocognition. If a patient develops adverse effect under one medication, it's always worthwhile to try another medication, right? And a change is absolutely warranted. So what should, in the end, choice of medications be based on? We talked about mechanism of action, efficacy, individual factors, treatment-related factors, adverse effects. And if we say we don't have a clear front runner here, so what I'm saying is that really the main factor is patient preference. So I think our duty as treatment providers is to really provide comprehensive information about different opioid agonists and opioid agonist treatments, potential advantages, potential disadvantages, provide comprehensive information about the alternatives and what that would imply, elaborate individual preferences concerning frequency of dosing, treatment goals, travel, etc. And then in the end, it remains really a collaborative decision on eye level made together by patients and prescribers, and not just by us telling the patients what to use. And again, in the light of this absence of a clear front runner, I think it's absolutely legitimate and warranted if a patient wants to change from one medication to another, or back again. This is absolutely legitimate. In our recommendations for opioid agonist treatment in Switzerland, we have this table which we translated for you in English. It's a bit of a guideline. Some of it is evidence-based. Some, I have to say, is also clinical experience by my colleagues and me. And this is like a traffic light system. With red, you should really look twice. It might be disadvantages. Yellow is neutral, and green is principally favorable. And we divided this by side effects, treatment factors, and efficiency. And yeah, I think the company will probably provide the slides, right? And you can also write me an email if you're interested in this. And this may help as a guideline how to choose a medication differentially. Those are the references. Just skip through that. I think I'm on time, Nick, to pass the, what do you say, the torch.
The torch, yeah. Thank you. Thank you, Mark. I should have highlighted before that the slides that we're going to be using in today's presentations will be available on the Cameras website, but give it a few days for them to load it up. So you don't have to write all the notes, but or copy all those references. So, from Mark's presentation, I'm then going to move on to look at some of the key issues around individualizing treatment. Mark's already highlighted some of the pharmacological and sort of the issues around medications and issues around some medications work better for some patients, there's safety issues, the subjective experience that some patients have on one medication rather than another. I'm sure you're all aware that some patients will say, look, methadone clouds me up too much, I don't like it. Other patients will say, buprenorphine, I'm too clear-headed, I don't like it. So this is very much an individual patient perspective. There's issues around what treatments are available in different countries, and also the stage of treatment. That when a person is entering treatment for the first time, their treatment goals might be quite different to where they are 2 or 3 years later, and might be different again 5 or 10 years later. So we may need to be tailoring the medications according to where the patient is in the treatment journey. So for example, in Switzerland, a patient might start on diamorphine, after a while transition to methadone, over to buprenorphine, and then naltrexone. So you could use all those medications over a treatment sort of trajectory. So they're the issues around the medications. But then we need to shift our focus to what I'd argue is probably more important, which is the patient factors. So in order to have good treatment planning and tailoring the treatment to the needs of the patient, one of the things the patient needs is good information in order to be able to do informed consent. And that's important for us to understand then, where do our patients get their information from? So for some individuals, it will be their own personal prior experience. I've been on methadone before, it worked for me well, I want it again. Or, I've been on methadone before, I didn't like it, I want something different. So their own personal experience. They also talk amongst themselves. So that peer, my partner was on methadone, didn't like it, I don't want to be on that either. Or peers in their network. So often that can be quite important in where they get their information. Occasionally they listen to us, the doctor or the nurse or the pharmacist, and we have an important role to play. Increasingly we need to be thinking about also how we develop information for our patients that is written in a way that speaks to them. And this is the importance then of partnering with consumers and with drug user organisations to develop literature which speaks to the patients in their own vernacular, in their own language, and in their own social settings. Increasingly also now we have to appreciate, with the newer sort of populations coming through, the importance of social media and media platforms like Reddit and other kinds of things, where increasingly people are going online to find out information about what other patients are saying about the medication. So we need to be cognizant of all those sources of information. Believe it or not, patients may read things on the internet which is not accurate. It happens from time to time. So sometimes patients may come with erroneous beliefs or misunderstandings about the way medications work. A common one, for example, is the buprenorphine naloxone. I don't want it because it's the naloxone and it's going to stop me from feeling my heroin. Again, it's a misunderstanding of what the naloxone is doing in the buprenorphine naloxone. So sometimes we have a role to correct misinformation. But we also need to recognise the importance of patient autonomy. And that means that patients actually have the right to make their own decisions around treatment and their treatment goals. And often I'm sitting there with a patient in front of me. I know what treatment they should do. It's quite easy for me to say, look, you should do this, this, and this. But that's not necessarily what the patient wants. So sometimes I end up having to go along with a treatment plan which I'm kind of thinking, this probably isn't going to work that well, but this is what the patient wants at this point in time. And it's more important for me to engage the patient, keep them in treatment, and if plan A works, great, we keep doing plan A. Importantly though, to be able to review the patient, monitor the patient, and then have that conversation. Plan A doesn't seem to be working that well. Let's think about other treatment options. So the patient autonomy in recognising that what patients want to get out of treatment is not necessarily what we want. And a good example there, and we'll talk about this, is looking at the difference between, say, sublingual buprenorphine and the depot long-acting injections, where we are getting some feedback through qualitative research, and you've no doubt heard it from patients. Some patients prefer a daily dose medicine because it allows them, for example, to not take the medicine on any given day, and it's easier for them to use heroin on that day because they don't have the blockade of the buprenorphine. Compared to a long-acting injectable, where the drug's in your system for a whole month, you can't really get away from it. So as a treatment provider, I'm thinking, well, I'm not really sure that that's a great basis to choose sublingual so that you can keep using heroin. But if that's where the patient is at that point in time, and I can't work with them to change their perspective, then it makes sense to offer them sublingual buprenorphine. So working with the patients around these kinds of issues, around understanding what their goals are, what their stages of change are, and also understanding the information they have. These are really, in many respects, the hallmarks of individualizing treatment for patients. Mark introduced this concept of the different classes of drugs, and now what I'm going to do in the rest of this talk is really focus on the transitioning between these groups of medications. So I want to look at the issue around how we might, from sublingual buprenorphine to long-acting injectable. That's, I think, fairly straightforward. Most of the product labels for both Sublocade and for Buvidal explain processes on being able to induct patients to transfer from sublingual to a long-acting injectable. But I want to look at some of the issues around going from a long-acting injectable to methadone, going from methadone to a long-acting injectable, and also look at issues around transitioning between long-acting injectable formulations. Increasingly now, more and more countries have either the Buvidal and the Sublocade or the Subutex depot available, and so now we sometimes have to think about, well, how are we going to transition a patient from one long-acting injectable to the other? So I'll touch on some of these issues for the rest of the talk. Just to highlight some of the advantages of long-acting injectables and also some of the potential advantages of daily medications. I'm sure many of you are familiar with the advantages of long-acting. The hallmark is that the patients don't need to attend regularly for dosing. That has a range of issues for patients. That often means less travel costs, greater convenience. Many patients have described less stigma associated with the treatment that you only have to attend once a month as opposed to having to take medication regularly and often having to hide the medication from either family or friends or from your employer and those kinds of issues. Obviously, the long-acting injectable has much lower risks of diversion and non-medical use of those medications. There's a lot of debate about whether or not long-acting injectables should be reserved for the stable patient who's doing quite well and, they can easily move on to that. And that's definitely possible, that you can easily treat a stable patient on sublingual, can easily be treated on a depot formulation. But the stable patient's actually easy treated anyway. The real challenge is some of our hard to treat and hard to engage patients. Initially, a lot of us were thinking that the long-acting injectables wouldn't work well for those patients because you would lose contact with them. And these patients need lots of monitoring and supervision, and we need to be seeing them all the time. Our experience is that there are some patients where that is the case, that they are so unstable and chaotic that actually the regular contact with the clinic, with the pharmacy is a good thing. But we're also noticing that there's a group of patients where less contact is actually better. Either because contact with the clinic often can result in conflict. So the patient who is frequently presenting intoxicated for dosing, and where the nursing staff or the pharmacy staff have to say, sorry, you're intoxicated, we're not dosing you today. That can cause conflict. The issuing of takeaways often requires us as doctors to sort of behave like police officers. Are you using drugs? Are you stable? So it introduces this dynamic where we're trying to catch the patient out from doing bad things. And again, that creates a tension with some patients. The long-acting injectables, our role isn't to be a police officer. So that often means we don't have to rely on as many urine drug screens and that kind of regular monitoring. And another advantage that we're seeing also with the long-acting injectables, I'll be talking about this tomorrow, there is emerging evidence that this medication seems to be an easier medication to stop with regards to the withdrawal syndrome compared to stopping sublingual bup or methadone. But there are advantages in the daily dose medications as well. Some of you will have heard or familiar, for some patients, the daily contact with a clinic or a pharmacy, for some patients, that's their community. That's the only social engagement they have. Going to the clinic every day is their network. And if you take that away from them, many of those patients feel lost. So even though the long-acting, you say to the patient, look, it's going to be so much more convenient for you. You don't have to come every day. And the patient's thinking, I like coming every day. This is my community. So for that patient, it doesn't make sense to transfer them onto a long-acting. We've mentioned before that some patients prefer the daily dose medications because that allows them to miss doses and then it's easier for them to use illicit drugs on top. And then there's also the issue that for patients who are quite complicated with drug-drug interactions or side effect profiles, or if you don't know a medication is going to be safe in a certain patient, for example, say severe liver disease, much better off to initiate and stabilise the patient on a daily dose medication because it's easy to titrate doses, and if something's not going right, to stop the medication and try something else. Harder to do if you've just injected someone with a monthly dose. You can't really do much for a month or so. So there are some circumstances where clearly daily dose medications have got advantages over the long-acting. Having said that, we are seeing more and more patients who are choosing, and this I think has to do with, we have a legacy in most countries of lots of patients on methadone. Historically, in many countries, methadone was the predominant treatment model. And increasingly now in those countries, they're starting to think about, well, how do I transition over to the long-acting injectables? And this is becoming more and more of an issue as we have a lot of aging patients, older patients. I think many of you will be aware that methadone probably adds to some of the safety side effect issues as patients get older. So obviously the biggest challenge in transitioning from methadone to buprenorphine is this phenomenon of precipitated withdrawal. I'm sure most of you are familiar with it. It has to do with the pharmacology. As Mark highlighted, buprenorphine is a partial agonist. It just does not stimulate the opiate receptor to the same degree that a full agonist will. You get the ceiling effect. But buprenorphine also has greater affinity for the mu opiate receptor than most full agonists. So if a patient, say, has methadone on board and they take a dose of buprenorphine, the buprenorphine can displace the methadone, and that results in a very rapid reduction in opiate activity. That can then be experienced as precipitated withdrawal. This is more likely to happen if you're transitioning from higher doses of methadone, and it's more likely to happen with a rapid onset of buprenorphine plasma levels. So if you've got a high dose of methadone, there's more methadone that can be displaced, and the greater the drop in opiate activity, and the rapid increase in buprenorphine plasma levels is also more likely to rapidly displace the methadone. So this has led to a number of approaches to how we look at transitioning. The first, I'll quickly talk about some of these, the conventional transfer, and then look at some of the newer models which are being developed around the world. So the conventional transfer, if you look at the product labels and the early literature from about 10, 15 years ago with buprenorphine products, the product labels usually say go down to 30 milligrams and then transition over. For many of us, we experience it's very difficult to get patients down to 30 milligrams. And indeed, not everyone needs to get down to 30 milligrams. Some patients are experiencing a lot of opiate withdrawal at a dose of 45 milligrams of methadone, for example. So for that patient, a transition from 45 milligrams may be adequate. So The principle has been bring the dose of methadone down as far as you can without the patient relapsing, obviously, into heroin use or significant cravings. When they're starting to feel uncomfortable in that dose of methadone, stop the methadone, wait until the patient goes into moderate to severe opiate withdrawal, say a COWS score of 12 or so, and then you initiate buprenorphine, sublingual buprenorphine. But you don't give a big bolus dose, you start trickling in little doses, like 2 or 4 milligrams, wait a couple of hours, another 4 milligrams, wait a couple of hours, at 8 milligrams. So you're generally trying to get at least 8, and I think most of us now would say 12, 16 milligrams buprenorphine day one with this conventional approach. The challenge for this is a lot of patients struggle to get down to a low dose of methadone, they may relapse, and a lot of patients are fearful of withdrawal. When you say to them, we're going to stop your methadone and wait for you to go into severe withdrawal, you see their eyes just widening. No, I can't do that. So this has been a challenge. The introduction of the depot, though, is actually, this is quite important for us to understand the pharmacology. Remember, precipitated withdrawal is more likely to happen with a rapid rise in buprenorphine plasma levels. With the Buvidal weekly product, you can see the difference in the onset of buprenorphine plasma levels compared to a sublingual dose. So with a sublingual dose, you get a rapid spike with a Cmax occurring about 1 or 2 hours after the first dose, and that's when you're most likely to see precipitated withdrawal. Compare that to the depot product, where you've got a much more gradual onset. So generally now, our recommendations and our advice is, if you're going from a methadone to a depot product, do not use test doses of sublingual buprenorphine. The test dose is more likely to precipitate withdrawal than your Buvidal injection. So in the Australian guidelines now, we pretty much say, when you are inducting patients on a Buvidal product, do not use test doses. You are likely to make the problem worse. So, one way to transition from methadone to the long-acting buprenorphine product and the Buvidal weekly, this is something now we do fairly routinely in Australia, is get the patient down to a low dose of 30 milligrams, stop the methadone. We do not need to see the patient scoring moderate or severe withdrawal. We don't need to wait for a COWS score of around 12. We are now going in at an earlier COWS score of around 6 or so, and then we give the dose of Buvidal. Usually a 16 milligram dose, and then we'll see the patient over the next day or two and then start giving them top-up doses of Buvidal, 8 milligrams. Most of our patients end up needing 32 or 40 milligrams of Buvidal over the first week. I'm just conscious of time. I might just skip this case study because of time, and I do want to move on to some of these other techniques because they're important to understand. Because of the problems of those conventional transfers, our colleague Robert Hemmig in Switzerland came up with the Bernese model, which has subsequently been called the microdose or the low-dose techniques. And the whole idea here is that you start initiating the patient with really small doses of buprenorphine whilst they are still taking the methadone. And then once you've built up the buprenorphine up to a dose of around 8 milligrams sublingual a day, you then withdraw the methadone and then aggressively increase the buprenorphine dose. So here's an example of a regime that we used in a big Australian study looking at this. You can see there gradual increases over the first week or so of sublingual buprenorphine, and then we stop the methadone over once we've achieved a high dose of sublingual. And this now is getting increasing use in many parts of the world. Some of the challenges here, it can be difficult to coordinate all this multiple dosing and splitting dosing. The transfer does take about a week. The main withdrawal discomfort that most patients experience is not in the first few days, it's actually in the days that you're stopping the methadone. So that's when often the patients are going to experience their greatest discomfort. And for all the potential benefits, the outcomes don't seem to be fundamentally different to conventional transfers. When we're looking at some of the bigger case series, and in our big study in Australia, we found about 80% success using the microdose transfers, which is what we get with the conventional. Another approach has been used for many years, but actually not many doctors used to talk about it, and it's something that many of us have been doing in hospitals for a long time. Often it might be in the circumstance you've got a patient on high-dose methadone with a QTc prolongation, and the cardiologist is saying, stop the methadone now. No, none of this slow titration or micro, stop it now. And then you think, okay, well, what am I going to do? I've got to stop the methadone now. So what we would then start doing is transitioning them from methadone, 120 milligrams for example, onto another full short-acting agonist. Morphine, oxycodone, it doesn't matter, they're all the same. The key issue is a short-acting opiate agonist, stop the methadone, allow 3 or 4 days on that agonist, allow the methadone to wash out, and then do a conventional transfer over to buprenorphine. We used to do these with sublingual, and now we would do this with directly would go onto a long-acting injectable buprenorphine, Buvidal weekly. The main advantage of this is quick. Like, it's basically the next day you stop methadone, and within 2-3 days they're on the Buvidal. But can be difficult logistically. In some countries they will not let you treat a methadone patient on morphine, for example. So it very much depends on the setting you're in. The other, just to wind up now, just want to comment on this issue around increasingly now in many countries, you've got the option of Buvidal and Sublocade, or Subutex depot. And of course, the two drug companies don't actually tell you in their product labels how to transfer between the products. So this really comes out of our own clinical experience and also some of the pharmacology, looking at the plasma profiles of the two products. So generally what we kind of recommend, if you're going from a Sublocade, 100 milligram, that would map out to a 64 or 96 milligram Buvidal, roughly, and a 300 milligram would be mapping to a 128 or 160 milligram Buvidal monthly product. These are just approximate initial guesses, and then of course you have to titrate the dose according to the patient's response. And very, very quickly this is going to happen. Patients who are going from long-acting, who turn around and say, I don't want the buprenorphine anymore, can I please go back onto the methadone? We see a lot of this in Australia, where in prisons the only treatment choice for many patients is long-acting. They leave prison, they go back into the community and they say, I don't want to be on this Buvidal. I've always preferred methadone. Can you put me back onto methadone? The general principle here is when it is time for the patient's next dose of the depot, which is either 7 or 28 days, depending which product you're using, at that point in time, stop the injectable buprenorphine and then you initiate methadone. And you initiate methadone as, like, we always initiate methadone on a lowish dose, like 30 or 40 milligrams, and then monitor the patient regularly and then increase the dose according to the patient's response and how they're going. Are they in withdrawal? Have they got cravings? Do they have side effects? You don't want to rush in too early with the methadone. Like if someone got a dose of Buvidal monthly today, I would not start methadone in 5 days' time. The challenge with that is you've got all this buprenorphine on board, which is potentially blocking the effects of the methadone. So you're pouring in methadone, bumping the dose up. Patient's sort of, not doing anything, doc. Okay, we'll put the dose up. And then the buprenorphine starts to wear off and you reduce that blockade effects on the methadone. So the risk is you overshoot with the methadone dose. So the recommendation, just go cautiously. It's methadone, you know, don't go too fast unless you're reviewing the patient on a very frequent basis. I don't think we have time for the case studies. I might just stop there. And please, can you also do the QR for the evaluation? Now, do we have time for questions?
I think maybe one question.
Okay.
One question.
It can be either to Mark or to myself. Oh gosh, I'm tempted. Can we do 2 quick ones? So, Adam first.
No, Thank you so much for reminding us about the principles and overviewing the field. A quick question for Nick about starting. Obviously, lowering methadone is often not possible below 100, right? Many patients don't feel well, cannot be really lowered. They still would like to try injectable bup, and I'm wondering whether you have at all tried giving 8 milligram Buvidal to someone who just took 100 milligrams the day before. Theoretically, you should not see any issues. We don't see issues giving it on top of fentanyl, but I'm wondering if you have at all tried that.
So if you do a search of a clinical trial registry, we've just registered a study, and we're just working through our final approvals for ethics committees, and that's something we're going to be initiating a study looking at that. So sort of doing a microdosing, but using Buvidal. And we're going to start off with low-dose methadone patients first. And if they go okay, then we'll up the dose of methadone. If they go okay, we'll end up looking at patients on 100 milligrams. So it will be an incremental, cautious approach. And we should start recruiting to that hopefully in the next month or so in Australia.
So I guess you have not done it. I mean,
no, not
you
yet.
may want to try it because I think from the US experience that should really be very non-problematic. And
yep, and that's why we're doing the study. But again, we need an ethical framework. It's a study. We need ethics. And we're also going to be doing that in an inpatient setting for the first injection. If something goes wrong, you do not want a patient in severe precipitated withdrawal in the community.
Right. I mean, you can manage withdrawal. It's easy to manage. But again, I appreciate the cautiousness. But again, often we don't have time. 2 years for the study to be published, it's too long, at least in the kind of US setting when things are changing very rapidly.
I have no doubt that inadvertently there will be patients on methadone who somehow accidentally are given a Buvidal injection. Yeah. But we usually don't collect data on that. There's one more question and it's for him, I hope.
Thank you. Any experience using transdermal buprenorphine as a microinduction agent in community settings?
I didn't get that. No.
Sorry, do you have any experience of using transdermal buprenorphine as a microinduction agent, particularly in community settings? I know it's been used relatively frequently within inpatient settings.
So there's lots of variations on the things I was describing. So microdose transferring, you can use sublingual. There have been people who have used injectable, and there's people using transdermal patches. The principle is all the same. Use a low-dose buprenorphine and gradually build the dose up. So, and there are now reports and papers being published demonstrating that transdermal is an alternative to using small sublingual doses.
My friend Puya Azar will be presenting this afternoon, and he will also, in his innovative solutions to fentanyl, he has perfected that stuff, and he's doing transitions in 24 hours, so you might want to hear that.
Okay. So on that note, I'd like to thank you all. I think we've run out of time. That's usually my fault. So thank you, Mark, and thank you all, and thank you to cameras, and please fill out your evaluations. See you later.
Thanks, Nick.